Hello and welcome to the 5th annual Pheochromocytoma Paraganglioma Awareness Week. We're investigating a historical mystery today. So we've donned our Sherlock Holmes deerstalker hats, and we're going to investigate a case from 1886, couch it in the history of pheochromocytoma, and even talk about my own case. My name is Chad Writing, and I am a pheochromocytoma patient. I had a pheo removed on August 31st, 2021. Joining us here today is Dr. Dhaval Patel. Dr. Patel is a board-certified general surgeon who specializes in endocrine surgery. He has joined the practice of Harold Chung Loy, MD, and Vincent Moss, MD, and is excited to be a part of the Hackensack Meridian Medical Group team. Prior to joining HMH, Dr. Patel was an assistant professor of surgery at the Medical College of Wisconsin and the National Institutes of Health. He has been published in leading journals such as the New England Journal of Medicine and the Annals of Surgery. He is a fellow of the American College of Surgeons and an active committee member of the American Association for Endocrine Surgeons. He is also a member of the Association for Academic Surgery, the Society of Surgical Oncology, the Endocrine Society, and the American Association of Clinical Oncologists. So welcome today, Dr. Patel. We're so glad to have you here to be able to discuss this historical mystery.
Thank you,
So as we begin, we kind of want to couch it, as I said, in the whole context of pheochromocytoma history, how we were able to find it, and everything. We did want to give, as we bring up this PowerPoint, we did want to give a brief kind of disclaimer that what we have here today is really, they're stories presented today for informational purposes only and should not substitute the advice of your doctors and medical team because they have in-depth knowledge of your medical history and current situation. So wanted to get that out there. We are here to have fun, explore the history, and really kind of raise the awareness and also let people know that, this mystery of pheochromocytoma and paraganglioma has been going on for a long time. So if there's mysteries about your case, I've experienced it. Dr. Patel, I'm sure, has seen it. We all have stories of this. So, what's interesting about this as I was going through the history is how recent of a diagnosed disease it is. They didn't come up with the first case until 1800s, at least, observing it, what they would later call pheochromocytoma. So that's 1800 in Ireland. And then in 1886, they came up with the case that we have today, which is the first scholarly journal article on pheochromocytoma. That's actually about 26 years before pheochromocytomas were first named. Paragangliomas, although rarer, were named about 4 years before that. And of course, pheochromocytomas were named because of the colored stain that came when they added Mullerian solution or Miller's solution to the tumor preparations. Also, what's interesting is that, I didn't really realize this, Dr. Patel, but the first successful surgical removal of a pheochromocytoma didn't happen until 1926, when Dr. Mayo and Dr. Vasquez, in 2 separate cases, removed their first. So we're 2 years from now, we're going to hit our 100-year anniversary of a successful removal. I don't know about you, but that just seems really late, but also given the state of the science and the fact that it has been such a historical mystery, it's not really that surprising.
I agree.
So, interestingly enough, is that the first surgical removal of a pheo was in 1926, but in terms of preoperative diagnosis and removal, so basically identifying a case and then removing it, that didn't happen until 3 years afterwards. So I'm wondering, and this is complete conjecture, I'm wondering, so they must have had some kind of surgery where they removed it, and then they were somehow able to remove it safely. without any kind of blockades. And then somehow the patient lived. To me, that's almost nothing short of a miracle. I couldn't imagine going into a surgery without blockades. So yeah, Dr. Patel, any thoughts about this?
Yeah, it's amazing that people were doing these surgeries without blockade. Without blockades, the mortality was almost 50%. So the fact that we can do blockades and now the mortality is down to less than 1% is pretty amazing. And it just tells you that we continually are advancing in taking care of patients both before, after, and during surgery.
Yeah, and that's a really important note. Like, they didn't even want to give me my surgery, which I totally understand is the way to go. They didn't even want to give me my surgery and really start to plan that until I had my alpha blockades in my hand. Literally in my hand. They're like, you have to pick this up at the pharmacy beforehand. And so fortunately, I was covered by insurance. But yeah, it was definitely interesting being on blockades too. I know this is a little bit of diversion, but blockades are very powerful medications, and they definitely do make you feel pretty awful, but it's all for the purpose of, you know, making sure that the surgery runs safely. So moving on to, you know, what I thought was really interesting too is that I thought this would come a little later. I didn't know that they had sophisticated blood tests, but the plasma epinephrine tests came around in 1939. So even before World War II, when, you know, penicillin was new. I thought that was actually really surprising to me that, you know, it didn't come later on. But you know, in order to really diagnose a pheochromocytoma, it's so helpful to have those levels to make sure that, you know, otherwise, they could do some kind of biopsy like they almost wanted to do on me. Fortunately, they stopped me before they had that. So in terms of your practice, like, could you imagine, like, you know, back in the 1950s, 1960s with the blockades, that had to be a lot of learning that took place as to how do you make this a safe surgery, what levels of blockades are appropriate. And as you said, you know, 30 to 45% mortality rates without the blockades. Any thoughts on this, Dr. Patel?
Yeah, it's, you know, even when we do blockade now, a lot of it's still clinical in terms of, you know, not every patient needs a certain amount. So a good endocrinologist and a good endocrine surgeon will give as much as you need to get you blocked. And we'll follow you, you know, do you have congestion? Do you get lightheaded when you stand up? Those are all signs to us that you have a good blockade.
Absolutely. Yeah, I remember when I was going through the surgery preparation process, I had to take my blood pressure twice a day, once sitting, once stand, and then immediately standing, and then look at it. And they're just like, no, we need to give you more blockades to push that down. And then eat. I was basically like gulping down soy sauce several times a day to get my salt levels high enough. I think I was high up to like 8 or 9 grams a day of sodium. So I grew to, I was like, oh, I can't have any more soy sauce. But it definitely was a great way to get your sodium levels up multiple
That's great.
times a
I think
day.
I'm going to use that too. I'm going to recommend that now to my patients. Try
Yeah,
soy
I mean, yeah, a tablespoon of soy sauce is like 1,000 milligrams of sodium. So, but I found that really helpful. So, moving on to the case of Mina Roll. On first thought, I was really amazed, like, that they had, reading the case, I was amazed that they had this much detail about an individual case back in the 1880s. Um, it was just crazy. I don't know, is this the first time, Dr. Patel, that you've really read a lot of old case files from the 1900s or early 1900s, late 1800s?
Yeah, actually, it is probably one of the first times I've read case reports from the 20th century, but not nothing that old. And I agree with you. It's amazing how uh, meticulous they were in documenting every little thing that was going on in Mina.
And you know what, when I was looking through the literature on this, on Mina Roll's case, an 18-year-old woman that was a farm girl doing farm labor in her what I would imagine is a rural community in southwest Germany near Freiburg. And she was starting to have these episodes that we'll talk about later. And they had, you know, the doctor had the foresight to document this. And what I thought was really interesting too is that these doctors are really, you know, Dr. Frankel and then later Dr. Chatelius, and then they were really pioneering members of the community. And what's interesting too is that, you know, I believe it was Dr. Chatelius, I might have this in my notes, like he was really into infectious diseases and not really into these kinds of tumors, which I thought was really interesting. This is like his only real foray into, you know, any kind of tumor or anything like that, which I thought was pretty interesting. So what I thought was interesting too is this is known as one of the first documented cases of pheochromocytoma in the medical literature. And of course, without the pathology reports, without those other things, it's really hard to say. However, you know, later articles, I think one from the mid 2000s was saying that they're pretty sure that this was a pheochromocytoma. Like given the title, a case of bilateral, completely latent adrenal tumor and concurrent nephritis with changes to the circulatory system and retinitis. Bilateral adrenal tumor, and then all the issues with the blood pressure and the vomiting and nausea. I mean, it ticks all the boxes. So, kind of in my case too, and I'm sure in your practice you see this, she'd been suffering for years, for 4 years. Every, you know, symptoms for a few days, every 6 weeks, then every 4 weeks. And then they became more frequent to every 2 to 3 weeks. Does that kind of jive, Dr. Patel, with what you've seen in your own practice with patients, that they become more frequent and they suffer for years with this disease?
Yeah, I've actually had a few patients recently that one came in with a funny heartbeat, atrial fibrillation, and you know, they diagnosed her with this, and then she had an adrenal mass, and she never was worked up completely. And then saw me 4 years later. I looked at all the things, and you put the mystery together, and you do the blood work or the urine, and you find out that she actually had a pheochromocytoma. And then I had another patient who had multiple heart attacks over 10 years. And there might, you know, be a component of just having heart attacks as you get older, but he also turned out to have a small pheochromocytoma that was clearly causing problems. And he even told me after I took it out that all the headaches and these kind of like anxiety, doom sensing feelings that he would get time to time just went away. So it, you know, I think a lot of patients, unfortunately, it takes a while for them to get diagnosed.
Yeah, it took me from when I might have had some symptoms back in 2012, but really 2014 that I can recall is when I had some symptoms, and that it wasn't until 2021 that we'll get to a little later when I go more into my story, is that I got a diagnosis. So I was suffering on and off for about 7 years, particularly on towards the end before the tumor was removed. And a final note about Mina is there's no family history of disease. Now, they didn't have gene testing back then. It's unclear if there was some kind of genetic component, but as we know, was it 40% of pheochromocytomas and paragangliomas have a genetic component to it? So I actually did my genetic testing. I don't have any of the markers, but my siblings were extremely interested in that part. But, you know, it's possible that this was not genetically linked. So kind of going into this case, you know, it's talking a lot about how she started to have symptoms at like 9 o'clock at night where she'd get the strong heart palpitations. She'd have a tremendous feeling of anxiety, dizziness, and pain in her head. That's like you could substitute Chad for those. And it would basically be like the same is typically evenings, but not always, but typically evenings, I would get these heart palpitations that would suddenly come on, a nasty feeling in my stomach, and then this sudden onset headache that would go away after a few minutes, but then I'd be left with nausea for hours, a lot of the time, especially towards the end. And how, you know, they became a lot more frequent, or that they were somehow triggered by certain events, weakness of vision as well. So, you know, these are things that they didn't have the medical knowledge that we have back now, and maybe they would have turned first to folk medicine or to some other, you know, healing method that they would have turned to, because I mean, you know, the germ theory of disease and other things, even though this isn't an infectious disease, germ theory of disease was relatively new when this happened. So that may not have, you know, reached the countryside where she grew up. Any thoughts about, you know, some of the symptoms that she has, and just the fact that, you know, she actually did seek help? I thought that was really interesting.
Yeah, I think all of her symptoms are classic pheochromocytoma symptoms. And, you know, as you know, Chad, it's very episodic. It comes and goes. And that's what makes it such a mystery and such a challenge to diagnose, because it's not consistent. You're not consistently sick. You get better, you feel better, and then you have this spell all of a sudden.
Do they have any idea of what might cause the, I wouldn't say periodicity, but just the fact that it like comes and it goes? Is there any idea?
Yeah, that's a great question, Chad. I think some people in the field believe that as the tumor gets larger, parts of it, the blood supply to that tumor as it gets larger is not enough. And that growing, that quick growing, results in some of the tumor dying and releasing epinephrine, norepinephrine all at once, and you get an episode. Other thoughts are that, you know, the adrenal gland is for adrenaline. So if you have some sort of anxiety provoking situation, some stressful situation, they're activated, and then again, a burst of release. And with the tumor, it'll be even a bigger burst.
What I hear too is certain foods will trigger it.
Mm-hmm.
And because I remember a couple times when I was eating in restaurants with friends and I'd have an attack, and I thought it was heartburn, which actually I did have, and we can get to how this led to my diagnosis, but I did have, you know, I did the pH testing, I had heartburn, and so I thought it was just like really bad heartburn because I had no idea what was going on. But there, people are like, "Oh, you're Chad, you're all the colors left your face." Like, and I was like, "Oh, I'm having a really bad attack." And as we've, you know, the medical literature has shown, pheochromocytoma is kind of like the ultimate mimic, is that it has a lot of symptoms of other diseases, because vomiting, dizziness, that could be a lot of different things.
Mm-hmm.
So her case progresses and she gets checked into the hospital. So this is, and what's interesting is that the end comes very quickly for Mina Roll. So what's interesting is, you know, they check her in on the 14th of December. She's good until the afternoon. And then she starts to, you know, get nauseous, have the vomiting. The doctor's very proactive. Dr. Frankel is very proactive about taking the blood pressure, recording the symptoms. Every time that she has, you know, heart pounding, things like that, she really does start to, you know, they do what they can about it. Looking at, you know, some of the medications they've given her, they give her ether. They talk later on about giving her digitalis. So lots of different medications that they have. I guess my question is, you know, they're giving her, I don't know, it just says injection of 1.0 of ether. It seems almost as if they're kind of hitting her with what they think might help, but it doesn't seem like they really have that kind of evidence-based medicine that we have today. Any thoughts on this?
Yeah, Chad, I think medicine has come very far from the times where we would kind of just try different things and see what would happen, to a very structured scientific process, see, is there a rationale for what we're doing? Is there a reason? So all the treatment we do nowadays for pheochromocytoma is based on evidence and trying to figure out the underlying biology of the disease. So, back then they would try ether, digitalis, try different things and see if the patient would improve. And unfortunately, she didn't.
Yeah. And the lack of, that knowledge, I mean, from a bioethics standpoint, now this is something where I'm really not super familiar with is, I mean, if somebody has symptoms and they're in these terrible situations and there is no concept of medical ethics, I mean, maybe it was just assumed then that at that time, that's what you do is you give them what you think will help them. But unfortunately, we have those diagnostic tests. So it does seem that she's able to, at least according to Dr. Frankel, that her headaches have moderated somewhat. But she still has these symptoms. The 15th, she has trouble sleeping. That's a clear sign. I remember when I had Pheo, actively secreting in me, I would wake up and I would be very, very sweaty, always hot and everything. Still having those palpitations and the dizziness. They talk a lot about giving her other medication, calcium bromide. They're very interested in her urine and some of the precipitates in her urine. Some of the sign too is constipation. That's another sign of pheochromocytoma. I had that. And again, that mimicked some of, stomach issues that they thought might have been caused by the heartburn. So, yeah, pheochromocytoma is a mimic, and if you don't have those tests and you don't have that knowledge, it seems like Dr. Frankel's doing what they thought was best for the patient. So then, some of the things they talk about, like a nosebleed, but they do talk about like the pulse frequency. That's one thing that's pretty easy to measure. Respiration, they talk a lot about. Irregular respiration, the pupils and the eyes. Is that something, Dr. Patel, that if you're a doctor and you have a pheochromocytoma patient, is that something that they can see that, pupils might be impacted when somebody's having an episode? Is that something that's in the literature?
Not that I'm aware of.
Okay.
I would be more concerned when the pupils are changing of a potential stroke. That's what would trigger me while I'm, if a patient with a Pheo came in and I saw them and they had, different pupils wider or differences and things like that, that's what would make me worried. But usually after surgery, not before surgery, because that's something I'll look after surgery.
Yeah, that's interesting. I guess, and we talk about, some of the medications that they give her that could have been, affecting her, having, digitalis, as they note later on, or the calcium bromide or the ether. They may not have been able to, come up with those associations between the medications that they were giving. Because I think, as far as I understand, the first really successful anesthesia was given probably only about 25 years before this case with, I believe, Queen Victoria when she gave birth. I think that's one of the first, surgical cases that somebody survived and had the anesthesia. So, and as we know with pheochromocytomas and paragangliomas, having a well-skilled, competent anesthesiologist is critical to that. So then, some of the symptoms continue for a few days, and that leads to Mina's last day. And so, they talk a lot about some of the things with the edema and general circulation issues, swollen feet, pains in the lower right jaw. Are those classic signs that some people may have with paraganglioma pheochromocytoma, or is this perhaps coming from some other source?
It's definitely not classic. It's atypical. I mean, we don't really know how long Mina had her pheochromocytoma. So if she had it for a very long time, she could have developed heart failure. She could have developed a heart that's at risk for heart attacks and things like that. And so it could be related, but it's very atypical.
So, and that's a really interesting point that you note about how long we don't know how long she had her Pheo for. It sounds like she had it for a couple years, well, about 4 years. Is that something that people are really, doctors able to ascertain how long someone might have had their Pheo for? Or is it just based on the symptoms?
No, it's based on the symptoms, but at least from expert opinion, we don't have great data for this, but when it's less than 2 centimeters or about an inch or a little less than an inch, you don't get as many symptoms. So, there's that lag period where you don't have any symptoms and then you start to get symptoms. I did have one patient though, he had one that was, I think, 1.5 centimeters, about a half inch, and he was having symptoms. But he also had one of the genetic syndromes. So it's not common, when they're really small. So the size can't really tell you how long. The symptoms are really what, and then you can add a little more time for when it was really tiny.
Okay. Yeah, because I'm just curious because I know my Pheo was 6 centimeters. It was big, and I had symptoms again for about 7 years before my surgery. So I've always kind of wondered about that because I have had anxiety issues, and I'm just wondering if that might have been related. This is before I started having some of the physical symptoms. So, I mean, you never exactly know, but it's something that's always made me wonder about that. And then one thing that I wanted to point out from the slide is that she has taken digitalis every 3 hours since yesterday at noon. Is that seems like a lot? Is that a lot, Dr. Patel?
That is definitely a lot.
Yeah, yeah, that is very much a lot. I mean, again, as we've kind of noted before, that they're kind of just winging it. Different situations with medical knowledge and procedures. Definitely we would take a different approach today. One thing I did want to note is, talking about some of those heart issues and circulatory issues, I talked to my surgeon not too long after my surgery, and I was just kind of saying, it's a little bit getting used to these, life after a Pheo. And he's like, yeah, well, I mean, you should be really glad your heart didn't fail on you and you didn't have a stroke and you're still alive. That's really the critical thing. And I'm like, that's actually a really good way to think about it, is like, through modern medicine and being able to diagnose me, I was able to get this diagnosis and have the Pheo removed. So it's something that we sometimes take medical knowledge and advancements for granted at times. And so going further into her last day, she's very anxious. She's very sensitive to any kind of motions, has a stomach aches, pulse rate is somewhat fluctuating, respiration also somewhat fluctuating. So she's really kind of starting to break down here. It sounds really terrible what she's going through, for days just suffering like this. And then on her passing, it came pretty quick. She was complaining of things that afternoon, and then she's at 8:45 p.m. She vomited sometimes. She lay on her side, visibly pale and cold. The nurse sent for a doctor, and then within 5 minutes, she was gone. So, I mean, it's a terribly sad story. It's very interesting how, it seems like had there been, modern equipment, kind of to help solve this mystery, she might have had like a pulse monitor. She would have had like blood pressure cuffs. I mean, we really would have been able to help save Mina. And it does make you kind of glad of some of the modern, miracles. Kind of talking about, some of the changes and advances that we have in pheochromocytoma and paragangliomas. Dr. Patel, what kinds of changes in your own career have you seen? Even though, you're fairly young, what kind of changes have you seen in pheochromocytoma and paraganglioma care?
It's been a huge change. So when I trained, it was 10% bilateral, 10% genetic, 10% family, something like that. And it's completely changed. I mean, now it's 40% are genetic. Everyone should get genetic testing. The risk of a Pheo is for your whole life. You get yearly testing to make sure it's not recurring. Laparoscopy. I mean, when I trained, laparoscopy was starting and it was still going, but now it's like the standard of care to do it laparoscopically or attempt to, unless it's really large. You had, when I trained, there was MIBG, but now we also have dotatate. We also have FDT PET scans. It's completely changed and changed for the better. And, we continually get better and better and improve with our outcomes. That 50% of mortality in the past is down to less than 1% now in experienced hands.
Yeah, which is fantastic. And it's really a dedication to the care teams that we have. I know when I was preparing for my surgery, I was meeting with, writing my endocrinologist every few days, had like several appointments with the surgical team, had CT scans. Unfortunately, I can't really do an MRI that well. I have so much metal in me that it's just some weird glowing blob in my abdomen area. But lots of things that we have there. Speaking about MIBG scans, I actually know somebody who is PhD in, I believe, nuclear medicine. And I, showed him my MIBG scans and they're like, I'd never heard of an MIBG scan before. So it's interesting how some of these tools that we have, complicating it is, it's really a very specialized field because it is such a rare disease. So I wanted to kind of share a little bit about my own history. So, as I said, I started having some of the symptoms in 2014. I was diagnosed with acid reflux in 2017. They tried everything to see what worked. And so they had me, and I did actually have acid reflux. They did the pH testing where I had a thing through my nose and down my throat for 24 hours. Not super pleasant, but you do what you have to do. So I had, unfortunately, the pandemic kind of pushed things out, but April 12th, 2021, I had a laparoscopic surgery to insert a Lynx band, lower esophageal sphincter augmentation device, to help alleviate those symptoms of acid reflux, because again, if you have untreated acid reflux, it can lead to a much greater esophageal cancer risk. So surgery went well. As I was in the recovery room, I had a hypertensive crisis where my blood pressure spiked to over 200. They're like, we gave you everything. We tested you for any kind of illicit drugs, clean. And so they're like, we just could not, find out what's wrong with you. We may never know. So I woke up, and in order to save my life through the hypertensive crisis, they put me in an artificial coma and they intubated me. Intubation is not fun, by the way. In any case, due to some reasons, they had to do a bladder ultrasound scan on me. And they're like, we see this like 7-centimeter long object in your bladder kidney area. What's that? And so my urologist is like, okay, yeah, let's do a CT scan on this. They did a CT scan. They're like, I found out by email, A, you only have one kidney. B, you have a 6-centimeter mass either on your kidney or your pancreas. And that was really emotional, finding out, oh no, I have a mass on my kidney or pancreas. And so that led to another CT scan, which led to like an MRI. Of course, the MRI didn't really work out because of the metal in me. And then they've scheduled a endoscopy And they're like, we think it might be like a sarcoma, so we're just going to do a little biopsy on it. It was scheduled for, I believe, June 4th, a Friday, 2021. The day before, Thursday, I got a call from the anesthesiologist, and he said, I am stopping this. This is not a good idea to do a biopsy because we think you might have a pheochromocytoma or paraganglioma. And so I was like, what? I didn't even know how to spell it. And so I went to Wikipedia and I'm like, what's going on? And so then they're like, we need you to do a 24-hour urine test. So you need to go off like vanilla and tropical fruits or whatever. I forget exactly, but it's somewhere around the bananas. And so I went off of that for 3 days. Then I did the test and then turned it in. And about a week and a half, 2 weeks later, they got these values. As you can see, some of them are pretty high. So 2,300 as opposed to 900. Some of them were extremely high, 11,000 compared to 1,300, or almost 9,000 compared to 400. So these are not great images because I had to take a shot of my screen. My epinephrine levels, 20 is what it was, the higher upper limit. I got 1,200. Norepinephrine, almost 700, where the highest value is 80. So we're talking almost off the charts on my epinephrine. This is pretty high, Dr. Patel. I'm assuming this is pretty high and pretty indicative of what you would think, oh, this has got to be something like a Pheo or a Para.
Yep, definitely.
So, yeah, and that's as soon as we got the results in, the endocrinologist contacted me as like, oh yeah, those, we think you have a paraganglioma, but it's hard to tell. So, they went in for an MIBG scan and tells my story about the acid reflux and elevated urine metanephrines and catecholamines and all these other things about the MIBG tracer and what they found. So left anterior perirenal mass is MIBG avoid avid consistent and norepinephrine receptor positive mass, which finding corroborates suspicion for paraganglioma, which, as we know, I believe, please correct me if I'm wrong, the new classification is that pheochromocytomas are more technically called intraadrenal paragangliomas. Is that the technical name, or I completely have that completely off?
It might be. I have not heard that though.
Okay, that could be me. So please, if anybody out there, my apologies if I use that term incorrectly. So then we move over to my pathology report. And, thinking about this whole theme of the history of the mystery and everything, how had this been available to Mina Roll, she would have never suffered, she wouldn't have died. She would have been diagnosed fairly easily. She had all of the signs, though of course I had a lot of the signs too, and I was missed for several years. So I think even with all the tools we have, that's part of why we do this paraganglioma pheochromocytoma awareness, is that we still need to get that awareness out there to healthcare providers, beyond just the few, the half hour or so that they may have as a general physician in medical school, that, we get this out there, that people understand, like, this is a disease. So even though it's rare, it still happens and it's important to take note of. And so you'll see my pathology report, 6 centimeters, pheochromocytoma, so capsular invasion. A lot of this is not really what not stuff that I understand as a city planner, but some of this, do they still make common use of the gap and pass scoring system in tumor? Okay. It seems though that some of the terminology kind of shifts and changes with paraganglioma as we learn, and pheochromocytoma as we learn more about this disease. Has that kind of been your experience?
Yeah, it's constantly evolving. The gap score and pass score, they're not widely used, but certain institutions, my institution uses it. And I think it just helps understand how aggressive this could be. What's the potential for malignancy? But truly, we don't have a good marker for malignancy unless you have like capsular invasion or something like that, or you have it spread to somewhere else. Then it's malignant, where
Absolutely.
it should be.
Yeah, I know mine had capsular invasion, but all of my scans and everything have been clear ever since. And I don't have genetic markers, so it says graded as a metastatic rate of 60%. So again, as you were saying, like every year we have our follow-ups appointments, and that's really important. And I'm very, very glad that I have a fantastic endocrinologist that is really cool about answering all my questions I have, is great about scheduling things, and understands the importance of this too, because I know, hearing about the community of pheochromocytoma paraganglioma is that not everybody has physicians that really that pay attention to some of these signs of pheochromocytoma and paraganglioma. So, as our time here kind of comes to a close, what are some things, Dr. Patel, that, some of the tools that you look for in diagnosing, and what do you think also are some of the future directions in paraganglioma medicine and pheochromocytoma medicine?
So in terms of tools, anyone with an adrenal mass should have blood work, urine work, metanephrines specifically. Metanephrines are actually the breakdown products of epinephrine. And so they are consistent. So some patients actually, how they have episodic headaches and things like that. So your epinephrine, your blood work, and your urine can also be sometimes episodic. Metanephrines, though, tend to be very, very consistent. And so, if I have a patient and I need to diagnose them, that's my first test, plasma metanephrine. Or the current literature also says you can do 24-hour urine metanephrines, norepinephrines as well. And then usually we also repeat the epinephrine, norepinephrine like you, just to confirm everything as well. So those are the tools I use. To me, I tell all my endocrine surgery patients that, endocrinology and endocrine surgery is all based on your blood work and urine work. If it's positive, you have it. If you are negative, you don't have it, most likely. And then in terms of future directions, I think hopefully we'll head towards more personalized care and medicine. And this really applies to patients with genetic mutations, which is almost 40% of patients with pheochromocytomas and paragangliomas, determining whether we should take out a part of the adrenal gland, the entire adrenal gland. Should we do it laparoscopically? Should we do it open? If we know it's SDHB, which is a mutation that B for bad has a high rate of cancer. So should we just do open to try to give you the best chance of cure? Should we take out the lymph nodes? All of these things are changing, and we're continuing to research. And I think it's exciting because as we learn more and more, we'll be able to personalize what we actually do and give you the best outcomes.
And as the medical technology, as the literature, seems to show the best way to do that, that's something, and especially as we have, large learning models, AI, I wonder that could also play a part at some point too, in the diagnosis. So it's really, in that regard, it's really exciting. But, kind of what really sticks out is, compared to before, when we had all, the blockades and the modern surgery techniques, we had a fatality rate of about 50%. And now it's under 1%. And so we're able to prevent a lot of the loss of life and the suffering that people have. I know my life post pheochromocytoma removal surgery is so much better. Quality of life, I can't even describe how much better it is, not knowing, oh, when am I going to have an episode where it feels like my head's, exploding, and I feel like I'm nauseous for 5 hours straight. So from that regard, I really appreciate doctors like you, endocrinologists, especially pheochromocytoma awareness. There are a few really key people in the community that I reached out to when I got my diagnosis that, took the time, spoke with me for over an hour, to kind of go through all of my questions. And it's really important to have a support team emotionally, because when you get, especially before I got a diagnosis, when they're like, you have a mass on your kidney or your pancreas, that's pretty scary, because I was like, oh no, is this pancreatic cancer, which has a much lower rate of survival. But, having that kind of support network, good doctors, really makes it a much more pleasant experience. Dr. Patel, thank you so much for your time today. Really appreciate your coming with me along this journey through time and to look at this mystery from the past. Thank you to pheopara.org. Thank you also to Jennifer Hunt, who helped with the edits on the translation. And thanks to all of you for supporting pheochromocytoma and paraganglioma awareness. We really appreciate the work that you've done. So anyways, have a great rest of the Pheo Para Awareness Week. Bye-bye now.